Dr. Neera, your co-host now.
Hello, can
Yeah,
you hear
Dr.
me?
Am I audible?
Yes, I can hear you.
Okay, okay. Now you're also co-host, so we can admit, right?
Okay. We should call Daga sir.
Daga sir, okay. We can call. Can you call?
Okay. I have only one phone, so it will be, I think, pause for a while. Huh?
Okay, okay, okay. So you are joining from the phone. Okay, okay.
Yes.
Okay, then let me call.
Okay.
Hello,
I
Dr. Aarti, Dr. Neera.
Yes, yes.
Hello.
Hello,
Good
good
Hello.
afternoon.
afternoon.
Good afternoon, dear.
Yeah.
Uh, just call Dr. Pawan sir
Huh,
once so
huh.
that he can join on time. And then just remind in the group that we are starting at exactly 2 o'clock. And
Okay.
this webinar is just for 1 hour. So keep that in mind that we have to finish up to 3 p.m. Okay?
Yes, yes,
Yes, ma'am,
yes.
sure.
Okay, dear.
Yes, ma'am. So should we call Dr. Pradeep Daga sir and Dr. Pawan Gulani sir also?
I have already told Dr. Daga sir, and
Okay.
already Dr. Aarti, you are a host now, and
Yes,
Dr. Ira Kanungo is co-host.
Yes,
yes,
Okay,
ma'am.
so
yes.
you have that means that you should keep quiet all the time for the other
Yes,
people
ma'am.
so that he can means narrate it properly,
Yes.
and you can begin with. Okay,
Okay, ma'am.
Okay,
Okay.
okay, ma'am. Okay.
ha ha. Just call Dr. Pawan Gulani.
Yes,
That's
ma'am. Yes, yes.
it.
Okay.
Okay.
Hello, Dr. Aarti.
Yes,
Have you informed Dr. Pawan, sir?
yes, yes. He will
Okay.
join within 5 minutes. That's what he messaged.
Okay.
Yeah. Good afternoon, sir.
Hello.
Good afternoon, sir.
I
Can
think,
you
yeah,
just
good afternoon. Good afternoon, yes.
yes,
Has
can you
everything
just
gone?
start? Yes.
Hello, Dr. Priyanka. I think she is mute.
So can you just start sharing one so that
Acha.
Hello, good afternoon, sir.
Good afternoon.
Yes. Dr. Aarti, please ask everyone to join fast. Sir has
Yes,
already
yes.
joined.
Yes.
Yes. Message in the group.
Yes.
Aswan. Aswan, मैं busy हूँ presentation में. अर्जेंट नहीं होगा तो 1 घंटे के बाद फोन करो. हाँ. Hello.
Hello.
Yeah, is it visible?
Yeah, it's visible.
Okay. And
Just make it sure whether the slide is moving or not.
sorry.
Slide.
Yeah, this is also visible.
Yes.
Yes.
Dr. Aarti, we will start within 2-3 minutes. Okay.
Yes, yes, ma'am. Yes, ma'am. Yes, sir. It's moving.
Yeah, it's working.
Yeah.
Yes.
I think everybody is busy with their Sunday routine.
Yes, sir. Sunday is like, but no problem. We will record it and we will post it for you.
Absolutely. No problem.
How was
Mainly,
yours?
we are going to be focusing upon the pathophysiology only.
Yeah,
What are the causes and what is the pathophysiology? Because the basic is very important in endometriosis. Once you know the
Yes.
basic,
Yes.
treatment becomes easy.
Yeah. Yesterday you were quite busy, so again we
Yeah,
have to
yesterday,
discuss Sunday.
yes. Yesterday was the emergency case, so cannot do anything.
Yeah.
Being an obstetrician first by profession.
Always on the toes and your job I have seen it's extremely difficult.
Can we start, madam, or still?
Okay, we can start.
Okay.
Yes, we can start. We'll recording.
Okay.
So shall I begin?
So, yeah, I'll just give you just intro. We'll just give you. So, good evening, everyone. On behalf of NIMA Central and NIMA OBGY Central, I welcome you all for this 36th webinar of OBGY Bonanza series organized by NIMA Central. Myself, Dr. Aarti Kulkarni, I'm coordinating this webinar with my co-coordinator, Dr. Neera. And it's my great pleasure to welcome all the dignitaries of NIMA Central, Dr. Ashutosh Kulkarni, Dr. U.S. Pandey sir, Dr. Shantilal Sharma sir, Dr. And then NIMA dignitaries of NIMA OBGY Central, that's Dr. Kamini Dhiman ma'am, Dr. Priyanka Nakade ma'am, Dr. Vishnu Bhavani sir, and Dr. Rajesh Utane sir. And I also welcome dignitaries of NIMA OBGY Maharashtra, that is Dr. Suhas Herlekar sir, Dr. Ajay Raj Bal sir, and Dr. Manoj Gaikwad sir. So I wholeheartedly welcome all the participants who are attending today's webinar. So now we are going to inaugurate the seminar virtually. So please join your hands and close your eyes. We'll seek the blessings from Lord Dhanvantari. Namami Dhanvantari Madidevam Sura Suraivandita Pada Padmam Loke Jararuk Bhayamrutyunashanam Dataramisham Vividhaushadhinam. So now it's my immense pleasure to introduce today's speaker, Dr. Pavan Gulani sir. His topic is allopathic management of endometriosis. So Dr. Pavan Gulani sir is MBBS MS and he has done fellowship in minimal invasive surgery and fellowship in infertility. He is consultant obstetrician and gynecologist, pelvic and laparoscopic surgeon and oncosurgeon. He is director at Medigrace Hospital, Nagpur and director at Inaya IVF and Fertility Center. He is visiting surgeon at prominent hospitals in and around Nagpur. He has operated more than 12,000 vaginal hysterectomies, more than 5,500 laparoscopic hysterectomies, and he has managed more than 1,500 patients of severe endometriosis with laparoscopic surgery. He likes to share his knowledge and promote laparoscopic surgeries. I request Dr. Pavan Gulani sir to please enlighten us with your immense knowledge. Please start your presentation, sir. Thank you.
So thank you so much, Dr. Aarti, for the elaborate introduction. And I'm extremely sorry for yesterday's chaos that has happened, and we had to schedule our webinar today. Yesterday we had an emergency surgery of placenta previa queria creta in bleeding phase, so we had to go and attend it. So let me start with a very important topic of today's era, and that is endometriosis. No practicing gynecologist is spared of this disease. Mostly everybody day in and day out must be seeing the patients who are suffering from endometriosis, or they are showing the symptoms of endometriosis. Okay, so what is endometriosis and why it is very important to know it? The prevalence of endometriosis may be as high as 25 to 40% in the reproductive age women. Roughly around 25 million women, that means around 2.5 crores of the women, are estimated to be suffering from endometriosis in India, according to the consensus of 18th March 2021. So it is a very high number, and even if you have suppose a OPD of 10-15 patients, you must be having at least 5 patients coming to you who are suffering from endometriosis. And who is suffering? Earlier the dictum was the endometriosis is a disease of influential people who are living in a city, who are having high spending capacity. But now things are changing. The data is suggesting that even the labor class patients are suffering from endometriosis. They are having the all kind of grade 4, grade 3 endometriomas and whatnot. So it is not just the people who are staying in the bigger cities, but also the people who are staying in the smaller cities are also getting affected because of the dietary habits and a lot of environmental factors, the food, dietary thing that we eat, the sedentary lifestyle, and much more that can be discussed in detail, and that can be another topic of discussion. Okay, so now let's see what are the causes of endometriosis. As we all know, the causes of endometriosis one of the main cause is a retrograde menstruation. You understand? And I personally believe that retrograde menstruation is one thing that is very important cause of endometriosis, because see, this is the uterus, okay, this is the cervix that we have, this vagina, okay, you have this endometrium here, and you are going to have the cervix close up, okay, and two fallopian tubes on both the sides. I hope everybody can see this. Understood? So because of the
Yes, sir.
influence that I have already told you, because of the estrogen, the high fatty diet that we are having, the sedentary lifestyle we are having, the obesity that we are facing, so all these combination is going to lead to higher concentration of estrogen in the body. And with that higher concentration of the estrogen, what is going to happen? Your endometrium is going to grow. It is going to go abnormally high. So nowadays we are seeing more and more patients coming to us with the increased menstrual flow. That is very common symptom that we generally see. So what happens with every menstruation? This increased endometrium is going to be shed off during the menstrual cycle when the patient starts menarche. So what happens? This increased endometrium, whatever ischemic endometrium has come out, this endometrium will try to squeeze in through the small pores of cervix. But because of the uterine contraction, the pressure inside the uterine cavity increases to higher level. And as we all know, if the cervical canal is tenosed or it is small, this fluid or this endometrial cell will be thrown out of the fallopian tube inside the abdominal cavity. You understand? So every cycle, this endometrium will be thrown out in the endometrial, in the abdominal or peritoneal cavity. And we all know the most common site for the endometriosis to develop is pouch of Douglas. And this probably will explain proper way that the pouch of Douglas is the most dependent portion in the pelvis or entire abdominal cavity. When you are standing, every fluid that is there will first accumulate in the pouch of Douglas. So this endometriosis is going to come and going to land up in this pouch of Douglas. So the most common site for endometriosis to form in the abdomen is uterosacral ligament and pouch of Douglas. Understood? So that's why retrograde menstruation forms the mainstay in the pathophysiology of endometriosis. Okay, one of the
Sir,
most
what
common
is,
and important.
excuse me, sir. Why it is less found, though the means the starting origin of the endometriosis from the fallopian tube, we have most of the time we have seen there is no tubal blockage in the during the endometriosis, and
It will never have. See, endometriosis is not going to rest in the fallopian tube.
yes,
Because fallopian tube has continuous movement. It has a cilia, it has a peristaltic
yes,
movement of its own myo architecture. So whatever is there inside the uterus or in the fallopian tube will be thrown out, either in the uterine side or in the peritoneal side.
yes. So
You understand?
that's the basic reason.
Fallopian tube is not going to keep anything that is there inside. It is going to be empty. Mostly whenever there are secretions also, those secretions are going to be emptied in the uterine cavity.
Okay,
That's
why
why
we
you are
kind
not
of
going to see any endometrium cells going and getting adherent inside the fallopian tube and forming any form of endometriosis there. So
okay,
most of the time the fallopian tubes are not blocked, they are kinked. They are kinked
yeah,
because of the continuous fibrosis. I'm going to come to that during the pathophysiology phase. Secondly, the cellular metaplasia. Cellular metaplasia is the second most acceptable theory. When you have endometriosis in the bladder wall, when you have endometriosis in the pleura, when you have endometriosis distant from the pelvis, there they expect that there is some constant irritation. These cells are going to be transformed into the endometrial cells, and they are going to respond to the estrogenic and progesterogenic cycle in the menstrual cycle, and they will form the endometriotic disease there. So cellular metaplasia. Then third is the stem cell giving rise to the disease, which spreads through the body via blood cells and lymphatic cells. These basal cells, those are there. They are forced inside the blood vessels or the lymphatic channels. But personally, I have never seen any patient like this where you're going to have endometriosis in the lymph nodes, where you're going to have endometriosis. See, endometriosis anywhere in the body can be is a fact. It is there, but the incidence is very low. So the most common theory that is accepted, and that what I believe is the retrograde menstruation theory. Okay, so why it is more important? Why do we need to know why what causes the endometriosis? Because we need to have the probably the uh, treatment in place that will prevent the endometriosis. Okay, so the way I told you that increasing the estrogen level because of eating habits, okay, the dietary habits, the stress, it is increasing the endometrium. Secondly, having the delayed pregnancy is going to keep the cervix closed. So more and more of the endometrium and the endometrial fluid is going to go inside the peritoneal cavity, and there are higher chances of formation of endometriosis. So these basic things, if we curtail, like eating the healthy diet or having a high fiber diet, eating less of the dairy products like cheese, butter, paneer, all these things will try and decrease the chances of endometrial hyperplasia and thus the retrograde menstruation. Secondly, having the early pregnancy. So this is also going to prevent the endometriosis. Okay. Now the pathophysiology is very important and very dear to me. Okay. So what happens in pathophysiology? Suppose this is the peritoneal cavity. Okay. This is suppose the plain peritoneal cavity, and I will just take the endometriotic patch like this. Okay. This is a small endometriosis that is going to come and get landed on the peritoneal surface. Okay. This is a small patch. What happens with this patch? This patch is nothing but whenever there is menses. Why does menses happen? Menses happens because it is a ischemic phenomenon. Because the under the effect of decrease in the progesterone, you are going to have increased prostaglandin increase in the basal layer. This basal layer will cause constriction of the arterioles, and this constriction of the arteriole will cause ischemia in the superficial layer of the endometrium. Understood? And this ischemic superficial endometrium gets sheds off, comes out of the cervix. If suppose this small portion of the ischemic endometrium comes in the contact of the peritoneum, see, the physiology says or the pathology says whenever you have any ischemic tissue, it has a blood hunger or oxygen hunger. You understand? So this ischemic portion is going to release certain chemotactic agent. It is going to secrete interleukin 1, tumor necrosis factor alpha, interleukin 6. It is going to 6 endothelial growth factors. All these factors are going to be released. And what happens by default, peritoneum being naive of all these things, it responds. It creates the blood supply that is going to supply blood that is going to come from the peritoneum to this ischemic endometrial glands or endometrial tissue. What happens once it gets the blood supply, it becomes viable. It is going to be alive. What is the problem later on? Later on, what happens? There is going to be estrogen. You are going to have the endometrium here. Okay, this is the uterus. I'm just showing you for the demonstration purpose. You are going to have this endometrium. Okay, you are going to have ovaries here, 2 ovaries. Okay, on both the sides. These ovaries are going to secrete estrogen and progesterone that is going to act on this endometrium. It is going to undergo hyperplasia, and then progesterone will come and affect the hyperplastic in the secretory phase and undergoes restructure or restabilization of the endometrium, and later on it is going to shed. So these same estrogen is going to act on this peritoneal deposit. Okay, this estrogen and progesterone is going to act on this peritoneal deposit. What is it going to cause? It is going to cause hyperplasia, then restructure or secretory changes, and then ischemia again. Okay, and again in the next cycle, whenever this endometrium has ischemia, okay, whenever it has ischemia, what it is going to cause is there's a pencil. So this ischemia ultimately is going to again secrete more inflammatory markers. Okay, more inflammatory markers. What happens in inflammation? You are going to have
Endometriosis.
pain. You are going to have swelling. You are going to have increased vascularity. That is rubor, tumor, and inflammation. Okay, so these are basically all the factors are going to act here. And after menstruation, what is going to happen? The estrogen and progesterone are going to decrease. So this portion will start after inflammation. There is process of healing. Okay, slowly this area is going to heal. And how does it heal? It heals by fibrosis. So what is going to cause? It is going to cause formation of fibrosis in this particular area, this entire area. And this is two-dimensional. I'm talking about three-dimensional tissue. When there is fibrosis, this fibrosis will cause constriction of this tissue around this pathology, like this. You understand? This has happened because of the fibrosis. Fibrosis are like string. The strings are going to pull the normal tissue around it. Okay, and it is going to form this cocoon around itself. Sometimes there is going to be another surface. Suppose this is peritoneum and this is the bowel. This bowel will try to curtail this inflammation, and it is going to try to avoid spreading this inflammation in the peritoneal cavity. So it is going to seal. This area will be sealed, and that's how it forms adhesions. So when you have active endometriosis, the adhesions are going to be more inflammatory. When you have given a lot of progesterone for the pain, you have given a lot of leuprolide or GnRH agonist for pain and for the conservative management, these adhesions are going to form into more and more fibrosis. You understand? Because in that particular phase, this inflammation is healing. And once this inflammation starts healing, it is going to form more and more fibrosis. So adhesions, those are there, will be more difficult to deal with. You understand? So whenever you give this patient a lot of leuprolide, lot of low molecular weight, lot of dinoges or progesterone, these adhesions are in the phase of healing, and dissection of these adhesions going to become more difficult. Are you getting it? Is everybody with me? Hello?
Yes, sir. Yes,
Yeah.
sir.
So are you getting the concept?
Yes,
Okay.
sir.
So once, see, now let's look at, this is the peritoneum I told you, right? But there are other things also. There is bowel. This is a supposed bowel that is going to be there in the posterior pouch of Douglas. You're going to have a uterus here. Okay. You're going to have this uterus here, and you are going to have a peritoneum that will be covering this entire area. So this is rectovaginal pouch. Understood? Do you understand? Suppose this same peritoneal piece is lying here. Okay. So what it is going to cause? What it is going to cause is, it is going to cause constriction. The same principle is going to apply here.
Yeah.
Same principle is going to form here, and the bowel will be like this. So it will appear as if it is invading inside the bowel. Are you understanding what is happening here? It is actually not invading, but it is actually pulling the surrounding area over it. So it appears as if it is invading. So the treatment here remains simple. There are so many people nowadays are doing resection anastomosis left, right, and center. If the endometriosis is the disease of anterior wall and you can shave it off, you can just remove this adhesion and shave it off from here without disturbing the mucosa or muscularis layer of the bowel. It can be very easily taken out, shaven out. But resection anastomosis will entirely cut this complete area. Do you understand? So the area that was supposed to be compromised was 1 to 2 centimeter. You are compromising the entire bowel lumen and the posterior wall of the bowel. In long run, what it does, it reduces the rectal capacity.
Okay.
Your rectum has a capacity of holding the stools. If your rectum size or the rectal volume decreases, your capacity of holding stool decreases. So the patient will have frequent defecation urge, because the body will feel that whatever rectum is there, it is totally filled with whatever amount of volume of the stool. So if you remove more and more amount of the rectum, there is lesser amount of the rectum that is left. This is the amount of the rectum that will be left, and this rectum will have more urge for defecation. So I have seen patients who are having defecation urge at least 8 to 9 times a day when everything is normal. Do you understand? So removing this nodule, that's why this pathophysiology is so important to learn. Understand?
Yes.
Okay. So this is one thing that I wanted to tell you, and just tell you more. Okay. Now we have taken care of all these things, right? We now we know everything, how the endometriosis is there. Okay, this is the rectum. Okay. I'll just clear this everything. Okay.
Sir, in that sonography images, can we come to know that there is an invasion inside the intestinal, or we just will require the?
There is one particular sign that they say it is a mushrooming sign. Mushrooming means this is bowel wall. The bowel wall has become like this.
Okay.
It looks like mushroom. This portion.
Acha.
This particular portion looks like mushroom. Can you see?
Yes.
That's why it is called mushrooming. You understand?
Okay.
That does not mean you have to completely remove the bowel segment. Understood?
Yes.
Okay. Now, another thing that what happens is, because the presence of this endometriosis here, as I told you, this area is going to be sealed. This area that is there is going to come closer to the uterus. Really sorry. This bowel is going to come closer to the uterus, slowly, and then it gets entirely adherent to the uterus like this. Are you understanding? Because of this endometriosis here, there is a process of inflammation. This bowel will come and get stuck here. This entire bowel will be stuck here. Okay? And when you see this endometriosis, moment you enter inside the rectovaginal space here, in this particular area, you are just going to have bowel, like paravesical fat, no, pararectal fat, sorry, or prerectal fat. Do you understand? This happens because the endometriosis is the surface disease. Otherwise, you would have had bad endometriosis in the rectovaginal septum also. But once you dissect that particular area of peritoneum, beyond that, the rectum is generally free. You are going to come, while dissecting, you are going to come from here. You are going to go paralectally, you are going to come from here. At a particular point here, it is going to be maximum adhesions. Once this adhesion is gone, the entire rectum and the vagina is going to be separate. Are you getting it?
Yeah.
Yes. So that is why it happens, because the endometriosis is a surface disease. Okay? And the thing that you have to do is, whatever can be removed from the surface, like peritoneum, okay, whatever affected fat, I'm not saying that fat does not get affected. Fat gets affected by fibrosis. Inflammation, in the process of inflammation, there is going to be inflammation around the tissue. When there is extensive endometriosis, the fat will also have an inflammation, and this inflammation will be healed in the form of fibrosis. And that's why when you have ureter and you have fibrosis around it, it can undergo compression. But this is because of the fibrosis. It is sequelae of the endometriosis, but actually it does not happen because of the endometriotic tissue. I hope you all are getting it.
Yeah.
Okay?
Yes.
Yes. So uterus, obviously the endometriosis is going to go inside the your endometriotic fibrosis is going to go inside the parametrial space, but not the actual endometriosis. Okay.
Yeah.
The way scarring is the sequelae of any infection. Infection is not present now, but scarring is present. The same way it happens in endometriosis also. The parametrial space will have more of fibrosis than less of endometriosis. And while removing this while doing the surgery for endometriosis, you have to remove the scar also, because post operatively, even if you give leuprolide, Dinoges, or whatever progesterone you give, it is going to act on the endometriotic tissue, not on the scar. The way your antibiotic acts on the infection, not on the scar. Whatever scar is formed is going to remain there for lifetime. And this scar can also give rise to dyspareunia, then cyclical pain during menstruation, or dysmenorrhea. So all these things has to be very, very clear while managing the cases of endometriosis. Okay?
Yes.
I hope I am clear. The same principle applies to the bladder endometriosis also. Same principle applies to the endometriomas also. In endometrioma, what happens? The endometrial deposits are deposited on the ovary, and this, when you have a follicle in that ovary, this endometriosis gets retracted inside the follicle, and every cycle it is going to secrete the blood, whatever blood the generally endometrium secretes, and slowly it is going to grow in size. Okay, that's why in the endometriosis it is not a pain because of endometrioma, it is pain because of the stretching of the capsule. Okay, so
Yes.
what are the symptoms? As I have already told you, it is a surface endometriosis is a surface disease. Okay, so the pain because of the superficial endometrium is going to be there. It happens because of the inflammation. Every cycle you are going to have congestive kind of a pain. The patient complains of that. That happens because of the inflammation that is there in the pelvis. The second is endometriomas. Endometriotic nodules, these are the main culprit for dyspareunia. Okay, this endometriotic nodule can also give rise to the compression on the ureters, and this compression on the ureter will give rise to hydronephrosis and hydroureter. Endometriosis is again an ectopic endometrium inside the myometrium. So adenomyosis is one of the form of endometriosis. Obviously, endometriosis is totally different entity, but it is not endometriosis, but it simulates the endometriosis, and mostly the adenomyosis is associated with endometriosis. Okay, so adenomyosis again can be focal or generalized. Then distance endometriosis or extrapelvic endometriosis that I've already mentioned, it can be there in the lungs, it can be there in the pleura, mostly because of the. So what are the complaints that patient has? The pain. Your patient is 99% of the time is going to complain of pain. It can be pain during menstruation, it can be pain during having intercourse, pain during having passing motion, and pain during passing urination. You can differentiate what kind of endometriosis you are going to deal when you are going to have this kind of complaint. Whether it is dysmenorrhea, so more of adenomyosis along with the endometriosis in the pelvis. Dyspareunia can be most likely because of the nodule I have told you. The dyschizia, that is the pain during defecation, can be because when the rectum is pulled because of endometriosis. Mostly the pain that is there in any kind of adhesion is not because of injury, but it is because of the pull on the normal structure. Okay, and dysuria is mostly because there is endometriosis in the bladder. One of the very important thing that is going to be there in the endometriosis is also it can have infertility, and endometriosis is not always comes with the any symptomatic complaints, and infertility is also one of the reasons. And then the indirect effect, as I told you, indirect effect like compression on the ureter. Okay, so how do we diagnose endometriosis? we do the examination. Okay, it is very important to do the per vaginal and per speculum examination of every patient who comes with pelvic pain. Okay, so what are we going to find is bulky uterus, and that is going to be tender. Fornical tenderness is going to be there. The POD, you'll have the uterus that is stuck. It is not moving at all. If you do a lot of PV examinations, you realize the normal uterus is mobile, and most of us who are used to doing the transvaginal sonography will also know with the movement or the probe that it is going to have the resistance. You're going to feel the resistance on the probe, and that way you're going to have that way you can diagnose. Then the important thing is ultrasonography. Okay, so ultrasonography, you can nowadays with the advanced previous probes, we know the endometrium. We can have the image of endometriomas. We can, even if you don't have endometriomas, you can have the ovary stuck to the uterus, and the when you try to move the probe, your ovary will not move away from the uterus. So that way you can find out whether there is endometriotic adhesions are there. Endometriomas, of course, mushroom sign, as I have already told you, that that can be because of the adhesions around the rectum, and you have to expect in this patient that the adhesions are going to be too much. So all the patients who are having this mushroom sign, you have to explain them the possibility of the rectal injury. You have to explain them the possibility of the ureteric injury, and most of the time, once you take out these adhesions, even if the rectum is open, you close them with the primary suturing. The rectum heals very nicely, so there is no problem. CA125, it is a dicey indicator for endometriosis, because CA125 is increasing multiple pathologies, but it is one of the marker for endometriosis. Most of the time when you have endometriosis, the CA125 will be raised in the rates of anywhere between 50 to 200 to 50. Okay, laparoscopy obviously is a gold standard method for diagnosing the endometriosis. Once you go inside, you can find, even if the patient is asymptomatic, you are doing it for infertility. You can go inside and see the minimal endometriosis, that is the powder burn appearance in the pouch of the cliff. You can see the mild adhesions around the ovary and the uterosacral ligaments. So you can diagnose with the laparoscopy. Okay. So endometriosis is again classified in stage 1, stage 2, stage 3, and stage 4 according to its score. And most of the time, what we are having nowadays is grade 4 endometriosis, where you are going to have adhesions all over the pelvis and causing the uterus and ovary to have restricted mobility. So what are the importance of having addressing the endometriosis? What are the benefits for the? It has one, health. Obviously, a female is with the endometriosis suffering from say 5 to 6 days of menses, and they are not able to work at all. So it is going to not just compromise on their physical health, but also on the mental health, their sexual health, and so many, and infertility obviously. So it is very important to address the endometriosis for that. Social, because of I have seen many women who are having endometriosis, having so much of pain. I will particularly tell you an instance of a patient who had come to me with endometriosis for last 7 to 8 years, managed conservatively. I don't know why. She was 38, 39 years, and I offered her hysterectomy. She was surprised. Why hysterectomy? So I said, you will know this once you are done with the surgery. So we have done a laparoscopic hysterectomy. It was a very difficult case, because she was given leuprolide and whatever multiple times. And I think I have operated her almost 1.5 years back, and now every month she messages me, thank you so much for advising me for hysterectomy, because she is so pain free now, that she had accepted that pain to be a normal thing for her. But once you are free of that pain, you are going to be your social life, your rest of the things, your even appearance is going to be so different. So it is very important to address the endometriosis and treat accordingly, whatever is needed. Okay, just doing conservative line of management for endometriosis is not the solution. Okay, economic also, because if you are dealing with a person who is working, so 5-6 days they are not going to attend their offices, their job, whatever. Like if they are earning, then obviously it is going to be a loss to the society. And there are women or there are girls who are not able to attend the colleges during the menstrual period. So you have to address this problem accordingly. Understood? So can we prevent it? No, I don't think in the present situation where we are industrializing the way India and the developing countries are under the immense pressure of development, it is very difficult to prevent it. But obviously, we can reduce it. We can teach our young patients to follow the dietary habits, do the exercises, try and not to indulge into fast and fried food. So it is going to reduce a little bit or delay the endometriosis, but prevention is going to be absolutely difficult. Okay. So what are the management? We have medical management. Okay. See, the endometriosis is just like malignancy, but it is not malignancy. You understand? Because endometriosis is going to be keep coming till the time you have estrogen in the body. Whatever treatment you give, you operate the patient, you remove entire pelvic peritoneum, you remove endometriosis, you remove the nodule. That does not mean that patient will not have endometriosis again. So you have to consider this disease as you have to explain your patient that this disease is a recurrent disease and the recurrence is known in endometriosis. What you can do is plan the treatment of the patient around her fertility needs. Okay, that is the most important thing. What are the medical management that we have? We have adjuvant and neoadjuvant. Because it is simulating the malignancy, we have added this word neoadjuvant medical therapy, because neoadjuvant chemotherapy is known, but neoadjuvant medical therapy can also be given in the endometriosis. So combined nocipills, progesterone, antiprogestins, GnRH agonist or antagonist can be second line of management. Okay. Surgical management, it is more precise and therapeutic, but the problem is the endometriosis will need expertise. Recurrence rate is less with the surgical line of management, or delayed probably you can say, as compared to the medical line of management. You have to do pre-op and post-operative AMH for this patient in the fertility age group. Okay. So what are the laparoscopic procedures that we do? We do adhesiolysis, we do ureterolysis and parametrectomies, we do peritonectomies, we do endometrioma resections, we do endometriotic nodule resections, we do total laparoscopic hysterectomy and BSO. This is a very important thing. Even if you have a patient of say 38, 40 years, where you know that ovaries will be functioning for more 10 years. If you want to remove the source of estrogen, because even after doing the laparoscopic hysterectomy or as I told you, giving a chemo like neoadjuvant medical therapy to this patient, there are high chances of having the recurrence under the influence of estrogen that is secreted from the ovaries. So if you have a grade 4 endometriosis, better to remove both ovaries for this patient. The rectal endometriomas, resection and shaving obviously. The segmental resection of the rectum, I don't really do it, don't like to do it actually. But if suppose you have a patient of multiple nodules, or the endometriomas or the rectal nodules who are more than 3 centimeter in size, then you don't have any option but to remove the portion of the rectum, or the segmental resection with the help of circular stapler can be done. Post-operative hormonal treatment, obviously it is absolutely necessary when you are dealing with the patient of infertility, and most of the patient you will be operating on are because of the fertility saving, infertility, or doing hysterectomies for pain. Okay, so if you are dealing with the patient with infertility and having having the endometriosis, it is obviously important to give hormonal line of management, and mostly what I prefer is to give there is one very important score, that is fertility endometriosis score. Okay, it is called FES or something like that. So what it does is it calculates the patient's age, it calculates intraoperative findings of the endometriosis, and it comes out with a score. And this score will tell you that whether the patient can go undergo normal fertility management, or it is going to require assisted reproductive technology management like IVF or ICSI. Suppose you have a patient who is young and their endometriosis is grade 1, grade 2. So you probably go with a normal medical line of management and then try to give her a pregnancy with the help of normal ovulation induction and IUI probably. And if you have a patient who is grade 4 endometriosis, age is more than 30, 33 years, where chances of pregnancy are very less. So you can directly offer them to go undergo IVF after giving leuprolide injections. Leuprolide will suppress the whatever remaining endometriotic foci are there, and then you can give them option of infertility or IVF. Okay, we have a very good result of pregnancies who have undergone treatment of endometriosis and undergoing IVF. Okay, most of the time these IVF patients they have undergone endometrioma resection, so the ANH reduces and they have higher chances of having donor IVF for them. Okay, this is endometriosis fertility index score that I was talking about. It totally depends upon the age, duration of fertility, any pregnancy history, then functional score of the fallopian tubes and the femori and the ovary bilaterally, and extensiveness of the endometriosis. So this is very important. You can counsel your patient accordingly. You can take a snapshot of this, probably the slide, and you can explain your patient accordingly. If you have endometriosis, and what are your prospective chances of having pregnancy post surgery? Okay. Now these are few surgery videos that I tried. I will include. Okay, this endometriosis. Okay, a large endometrioma on the right side. You can see the big endometrioma that is drained. Okay, if the endometrioma ruptures inside the peritoneal cavity, it is not going to cause any increased spread of whatever disease. Okay, so the idea of doing endometriosis surgery is to remove as much as endometrioma as possible. Okay, this is again the rectum. I told you this is a particularly place where this is the rectum that is adherent in the pouch of Douglas, and this is the pararectal space that I'm trying to dissect. Understood? And it has fibrosis there also. Once you cut this particular portion, you see this is the rectal serosa, a small injury to the rectal serosa. It does not create any problem. Once you cut this particular portion, you'll immediately land up into the rectovaginal space, and that rectovaginal space is absolutely free of any adhesions. Understood?
Yes.
These are all sclerosis or scar. Okay?
Yeah.
There's a pretty old video that was there. I included this
These
slide.
are not means it's not getting cleared properly.
Sorry?
Videos are not getting cleared properly. If it is possible later on, can you share it in the group so that we can again
You can see now. Is it visible or it is absolutely not visible? Because on my side it is absolutely
visible.
perfect.
It is visible little bit, but not the clarity is not.
Okay. Now you can see the rectum is totally separated, and below that you see this healthy fat. You can immediately realize the color of the fat and the wall of the rectum. So this is what I was trying to talk about. That the endometriosis is a disease of surface. Okay. Now the entire rectum is separate there, and bilateral uterosacral ligaments are also free. And then this is the removal of the endometrioma. Okay. The principle of removal of the endometrioma is, if you tear the tissue, you will realize that the endometrioma and the ovarian tissue will tear at a different pace. Okay, so you can just go inside and what do you call, peel off the endometriotic cyst. Okay, once you are in the good plane, there are lesser chances that you'll injure the healthy ovary, and once you are in the good plane, there are lesser chances that bleeding is going to be there. You can notice there's hardly any bleeding is there. Okay, and the maximum portion of the normal ovarian cortex can be preserved.
Yeah.
Okay. But the prerequisite is is to be in the normal plane and shear off only the endometrium. Suppose you just drain the endometrium and leave it and try to give the medical line of management, you'll have 90% chances that in 3 months patient will come back with the same size ovarian cyst. Okay, so and also it has higher chances that that endometrium will get infected, and infected endometrium operation is horrible. Okay, so rather than doing that, just take it out, whatever size of endometrium you have, even if it is 2 centimeter, 3 centimeter, it is better. If you have gone inside for the treatment, take it out. Okay.
Yeah.
And as I told you, if you are in the good plane, there are lesser chances that you will have any injury. This is again a video of lateral pelvic wall dissection. This is just to show you the anatomy. I suppose many of you must have seen this video on YouTube also of lateral pelvic wall. This is the ureter that you see there. Okay, it is very important for all of us who are operating the endometriosis to know the lateral pelvic wall anatomy thoroughly, because endometriosis, you need to dissect the ureter till tunnel, and you need to dissect the rectum till the rectovaginal space. If you don't do that, you are going to have more and more trouble. Okay, because chances of injury increases when you don't identify the tissue and dissect it. Understood? So this is the ureter. You can notice this is the rectum that is there. Okay, this is the internal iliac vein. Okay, that is there. So this video is just to demonstrate the lateral pelvic wall anatomy, nothing else. This patient does not have endometriosis. This patient we have operated for CA endometrium. Okay, you can see this, the internal iliac vein here, big vein. It is a pararectal space, and this pararectal space will also have a very beautiful nerve, that is inferior hypogastric nerve. Can you see this white structure here? That is inferior hypogastric nerve.
Yeah.
Right. So why it is important to know? Because in endometriosis, it is just like operating the malignancy, where you have to spare the nerve. If you don't spare the nerve, you will end up in having a patient of you can see the nerve. Okay, you can see the fibers, those are coming from the sacrum. Okay, so you have to do the nerve sparing surgeries for this patient. And this is actually the retrorectal plane. Here you can see the nerve that is going to the rectum also. You can see the nerve fibers. Okay, so this is the retrorectal space, and this is here there is a coccyx. Okay, can you see this white thing? It is a coccyx. Okay, obviously it is not needed for all these surgeries, but just to know the and beyond the coccyx you are going to have your pelvic floor. Okay.
Yeah. If you
Again, this is
accidentally
the
rupture the nerve, sir, if you means if during the operative, if we coincidentally, if it happens, then what
injured.
means after
Generally,
that
what happens is hypogastric nerves are supply. There are bilateral nerves. Even if one nerve is compromised, most of the time when we are doing a laparoscopic hysterectomy and you have a parametrial involvement, there is obviously there are higher chances that one side of the nerve is compromised. One side of the nerve, even if you compromise, that doesn't make a lot of difference. Okay, the second side will take care. But if you go and compromise both the nerves, then the patient will end up in neurogenic bladder. Okay.
Yes.
So if it is partial injury, then it is good. it will have a neuropraxia. But if it is a complete injury, then your patient will be having a lot of problems. So
This is
again,
the
this is
kissing ovary sign.
sorry.
Kissing ovary sign that you have shown.
Yes, this is the kissing ovary. I think yes. This is the kissing ovary again for laparoscopic hysterectomy. Okay, you can understand how difficult and how dense those ovaries are attached to
Yes.
each other. Okay, again, as I told you, this all the thing will require the dissection of the lateral pelvic wall, and that's why lateral pelvic wall anatomy is very important. Okay.
Yeah.
I have little fast forward this case because this case is the laparoscopic hysterectomy. We have seen multiple surgeries like this. Okay, so your any dissection of the lateral pelvic wall begins with the dissection of the sigmoid colon. Okay, and this is the plane of I have identified the ureter, and this is the plane of pararectal space. Understood?
Yes.
And if you notice, we are operating most of the surgeries that we do with the two ports. Okay, unless it is required. Okay, this will ease the pain, and also cosmetically it is better. Okay, you notice it's totally sealed. This is the rectum. You can see the rectal wall has come here. It is important to identify the pararectal space in these cases, and then go ahead with the further dissection.
Okay.
This is again the dissection of ureter on the other side. This is the rectum that was stuck, and as I told you, once you dissect the adhesion, that adherent portion, the rectum will be totally separate and free. Sometimes the rectum is so close, so there are chances that you might give a nick on the rectum. Okay. This is again a redo surgery. I think Dr. Priyanka was present when I was operating this case. This was a case that we operated at Buttipuri. Dr. Priyanka.
Yeah.
It was a horrible surgery. It was a case of endometrioma. The endometrioma was not completely done. Adenomyosis was not completely properly operated, and the kind of adhesions that we see, the entire sigmoid colon that is got adherent to the adenomyosis. Okay, uterus. Uterus was very big. Uterus was almost 12 to 15 weeks.
It was so distorted that even we can't see where is the ureter, where is the...
Nothing was visible.
Nothing was visible.
And
it was so distorted.
This thing, that bleeding that you see, it is a sign of inflammation that is there. Okay, so every endometriosis will have. Normal adhesions are not going to have this kind of bleeding, but endometriosis will definitely have it. Okay.
Yeah.
So this was one hell of a case that we have operated. Okay, that's it, I suppose. You can see the entire raw area. You can see all the bilateral ureter were dissected and cleared. Okay.
We would like to see this surgery, sir. If you have that, means the full surgery if recorded, and we would like to.
Absolutely. So now, what are the take-home messages? The endometriosis is all around us. Open your eyes and address the issue. Okay. So it is impossible if you are doing a case. If you are doing, suppose, if you are doing OPD of 50 patients and you are not seeing endometriosis, it is because you are not seeing the endometriosis at all, or they say that what your mind knows, your eye sees. Okay. So you have to be aware. You have to be give attention to the endometriosis. Just having a pain and giving painkiller is not going to solve the problem. Because if you find a disease early, you can start the treatment, and you can at least advise the patient that you have endometriosis. You have to have this kind of problem. she will be ready at least, because if you keep giving her treatment the way I told you the example of the patient who was taking the conservative line of management for 8 years, it is not going to solve her problem. Okay. Not all the cases of endometriosis require treatment. Okay.
Yeah. But sir,
Okay.
in the
If
low
you have
AMH with the infertility patients, means who are seeking for the pregnancy and having the very low AMH with grade 4 or 5 endometriosis, at that time particularly, means we should consider the symptoms first and then go with the means if she is having the endometrioma, which may carry another means after post-op the low AMH will get reduced. So in that case, whether we should go for the operative or whether we should means see for the AMH or the storage of ovarian means
see,
actively.
even if you have a patient who is endometriosis and the AMH is very low,
Yeah.
anyway she is going to require IVF, right?
Yeah.
Understood. Totally depends upon what are the symptoms of these patients are.
Okay.
If she is having pain, definitely she requires surgery. If she is opting only for pregnancy, then you might as well go for IVF directly. Do the hysteroscopy. If uterus is absolutely normal, you can go ahead and do the embryo transfer. There is no problem.
Okay.
Okay.
Yes.
Then the laparoscopy is the gold standard in the management of endometriosis. Okay, it is a well-known fact now. For adequate management of endometriosis, knowledge of the pelvic anatomy is must. Okay, and when combined with the ART, endometriosis patient can be benefited. Okay, so thank you so much. These are the YouTube link and the Facebook group that we have. Thank you. And I have a news to announce that very soon Medigrace Hospital is going to be equipped with 3D camera. This month end, maybe in 7 days, we are going to have Ascolab system, entire system with us. It is a fantastic German system that that is going to give us edge over multiple systems for management of endometriosis, radical surgeries, and all difficult laparoscopic surgeries.
Wow.
Thank you so much for giving me an opportunity.
We can see you the live surgeries on that.
Yes, we can see the live surgeries with the 3D system now.
Very nice, very nice. Okay, anyone of you have any questions?
Yes, ma'am, I'm starting with that. Thank you, sir, for your valuable sessions. I would like to ask you, sir, what lifestyle changes might help in endometriosis?
See, the lifestyle changes are mostly there are a few things I've mentioned. First of all, following the sattvic diet. I think you know it better.
Yes, sir.
Okay, so having a lot of high fiber, low carbohydrate, high protein, low saturated fat. So all those fried things are gone away. All those gluten things have gone away. All the sugar things have gone away. Okay, should go out of your diet. Then cheese, paneer, butter should go away, because the food that has more estrins are going to have natural estrins are going to have more propensity to form you more estrogenic milieu in the body and endometriosis. Okay, your daily exercise, yoga is going to be very helpful. Stress is one of the very important reasons for increasing the chances of endometriosis in the patient. Delayed marriages and delayed conceptions are one of the very important, because your body and your peritoneum is going to be keep on getting exposed to the getting exposed to the endometrium that is shed from the retrograde menstruation. So all these things are very important. Obviously, if you go in details, there are multiple things that we can tell you, but in the rough guideline, all these things have to be done to delay or prevent the endometrium. Prevention obviously is very difficult, but you can obviously delay the symptoms or appearance of the disease.
Okay, thank you, sir. One more I would like to ask. Is there any role of menstrual tool used by a female in the pathology, sir?
Menstrual tool as in?
Menstrual tool used by a female in pathology of endometriosis, like menstrual cups or tampons?
No, it does not have any role. Because once even tampon or menstrual cups are used beyond the cervix. and we are talking about constriction of the cervix. You understand? So it does
Yes.
not make any difference using the cup or tampon or pad in the patient. It doesn't make any difference.
Okay, sir. And first line of approach to infertility patients in endometriosis, sir?
See, first line is always for any any infertility patient, I would suggest to do the baseline workup and ultrasonography. And obviously the clinical examination. If you have an endometriosis, you have a fixed uterus, then your line of management totally changes. If you have a free uterus, and patient is not conceiving for 5-6 cycles, there is a possibility that you are missing the minimal or mild endometriosis. So the basic infertility approach is going to be the same. You have to do your basic workups, do the AMH of the patient. If everything is normal on clinical approach, you can give her 2 or 3 cycles. If it is she's not conceiving, then probably go for laparoscopy, diagnostic laparoscopy. You'll find the minimal to mild endometriosis. When it is treated, you'll have higher chances of pregnancy. If your patient is having grade 3, grade 4 endometriosis, you are definitely will have to go laparoscopy immediately before even giving any trial of pregnancy with ovulation induction, and probably go for IVF after that.
Okay, okay. Thank you, sir. Thank you so much. Okay.
Yeah.
I would give thanks to everyone. On behalf of NIMA-National Society, I would like to express my gratitude to NIMA President Dr. Ashutosh Kulkarni, sir, Treasurer Dr. Shantilal Sharma, sir, for the remarkable support, and Secretary Dr. U.S. Pandey. I would like to thank Dr. Kamini Dhiman, Madam, Dr. Priyanka Nakle, Ma'am, Dr. Rajesh Utane, sir, Dr. Vishnu Bhavan, sir, for their guidance and support to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Pawan Gulane, sir, who took time from the busy schedule and delivered very knowledgeable and wonderful session with us. Thank you, NIMA-OBGY President, Dr. Suhas Helkar, sir, Secretary Dr. Manoj Gaikwad, sir, Treasurer Dr. Ajay Pal, sir, for supporting us for today's webinar. Would also thank Dr. Prajakta Patil, ma'am, Dr. Girish Daga, sir, for the help in technical support and guidance. Last but not least, I would like to thank from bottom of my heart to all the delegates for the participations and presence. Without them, this webinar would not have been possible and success. Now, with due permission to all the dignitaries, I am concluding today's webinars. Thank you for attending and hope you all have learned and gained knowledge from today's session. Thank you. Thank you so much.
Thank you.
Thank you. Thank you, sir. Thank you, sir.
Should I end the meeting?
Yes,
Yes.
Doctor.
Yeah.